You.
Thank you, David. Well, thank you for all having me. David this morning was giving me a bit of an introduction to the CHEAR group. And my understanding is, I'm a psychologist, as David said. My understanding is that all of you, or most of you, are biomedical researchers in one field or another. Are there anybody here doing, besides David, doing clinical research in psychological or psychiatric areas? Okay, so I will be very interested in hearing your responses, biomedical researchers, to what I'm about to present from psychological and behavioral research. So what I'd like to do today is use the development of a clinical intervention called Bright Ideas. Bright Ideas is a cognitive behavioral problem-solving skills training program, which has been used in many different populations. What I'm going to describe today is its application with parents of children with serious life-threatening illness. What I'd like to do is to talk about the evolution of our research in this area, to highlight some key concepts that many of you may be familiar with, which are fairly new in behavioral research in terms of what we've seen. I'm talking about measures of clinical treatment efficacy, treatment specificity, treatment dissemination, and treatment responsivity. You know, randomized controlled trials are sort of the gold standard of how we choose clinical intervention, how we choose what works in evidence-based treatment. But what I'm going to do today is kind of take a closer look at that. So first, I'd like to, this kind of research, it's multi-site research, as I'm sure many of you are involved with. And I'd like to acknowledge my collaborators who I've worked with over a few decades and who have become all close friends, and without whom all of this, of course, couldn't have been done. So the first randomized trial I'd like to talk about took our Bright Ideas problem-solving skills training program, which I'll describe and I'll give you a flavor for a little later in the talk, and we tested its efficacy. Before I go into the study itself, I want to just give you a little bit of a theoretical background. Okay, problem-solving skills training derives from problem-solving theory, which basically talks about two pathways: constructive problem solving, which consists of, well, in general, when we approach a problem, there's the way we think about it and what we do about it. The cognitive component is the way we think about it, which can be either positive or negative, pessimism, optimism, self-efficacy, etc. And there's a behavioral component in terms of how we approach it, which can be rational, which I'll describe shortly, or it can be impulsive, careless, or it can be avoidant, just to stay away from the problem. The intersection of positive problem orientation, the way we think about it, and a rational approach leads to constructive problem solving, and negative orientation and either impulsive or avoidant behavior leads to dysfunctional problem solving. This, again, of course, has been tested and demonstrated in a variety of populations. In fact, if human beings approached problems this way, in a constructive way, we'd all be better off. The conceptual model posited that there's a crisis in the family, cancer. We have an intervention which we think can help parents deal with this crisis. The primary outcome, since we're intervening to affect problem-solving skills, so the primary outcome is improved problem-solving skills. And our hope as clinicians is that it'll lead to secondary outcomes in the form of decreased negative affectivity, better mood, less post-traumatic stress, etc. So our first study was a two-arm randomized controlled study that tested problem-solving skills training plus UPC. In other words, usual psychological care. This was conducted on pediatric oncology wards, so there's perhaps a psychologist, social workers, there are different kinds of interventions going on all the time. But in one arm of the study, we added an 8-session problem-solving skills training intervention. And that was compared to a no treatment control group for our purposes, which was the usual psychological care only. The sample sizes are in front of you. The subjects were mothers of newly diagnosed cancer patients shortly after diagnosis. And our measures, the primary measure was problem-solving skills, and the secondary measures were affect, how these people actually felt. 3 assessment points, pre-intervention, immediately post-intervention, and 3 months post-intervention. And these are the measures we use. The first one is social problem-solving inventory being our measure of the primary outcome. And the next 3 being psychological measures, looking at mood, affect, and post-traumatic stress. So these are the components of the problem-solving skills training program. But what I want to do with Steve's help, instead of going through this, or Steve.
He's right here.
There you go. Okay. Is I'd like to show you a real quick video, 4-minute video that will give you a kind of a flavor for what the intervention is about. So help me get into.
Stop share.
What's that? Stop share.
Stop share.
Okay.
Escape to
Okay.
get out of the.
Oh, here it is. Here it is.
Yep.
Click on that.
Then go back to the Zoom meeting, share again.
Right, there you go.
Pick up the share.
Yep, share.
Okay, go back
Share.
to here
Oh,
and,
you didn't hit share though.
share.
oh, sorry, go back and hit share. Share.
No, right above it, the blue,
Up above,
blue button,
blue.
right above it, right there.
Oh, I see.
Now you can start your video.
Now ready to go?
Yes, sir.
Here we go.
The audio is not.
The audio did not share in the Zoom, so we're gonna try this one more time. Stop share. Share. Here we go.
Share sound.
Share sound.
Learned something new today.
I'm
Some of my steps.
gonna start over just so they can hear all that. Begin. Thanks, you're welcome.
Hello, and welcome to the Bright Ideas Online Problem-Solving Skills Training Program website. I'm Dr. O.J. Saylor. I'm the Program Director for Psychosocial Oncology and also for the Long-Term Survivors Clinic at the Golisano Children's Hospital at the University of Rochester Medical Center in Rochester, New York. Over the past 20 years, it has been my privilege to work with a group of truly talented and innovative psychosocial oncology researchers whose goal has been to help to decrease the stress, anxiety, and depression that oftentimes accompanies the diagnosis of cancer in a child in the family.
Your whole world becomes upside down. Everything that you thought was okay now is no longer okay. It's very easy to feel like you are in a cloud and you don't feel like there is much of a way out. The Bright Idea really helps you change that kind of mindset to look for the ways out and what you can do. And even it helped me stop and think, okay, here's the situation we're dealing with now. How can I look at it in a positive way? How can I find what is good? How can I see beyond what is just right here to what is over the hill?
Actually, learning how to problem solve is a skill that can be used in any aspect of life. How to communicate better in your family, how to do your job better, how to be more effective in the community. Essentially, there is no issue that doesn't lend itself well to a good, effective problem-solving strategy. Now, problem solving comes naturally to some people, but for most of us, it requires an understanding of the system of problem solving and practice. The website that we have designed for you is one which we hope will engender in you a sense that you can be optimistic about your ability to solve the problems that you are facing. And optimism is the bright in bright ideas. And then the word ideas, I-D-E-A-S, actually spells out the 5 steps of problem solving. I, identify the problem. D, define your options. E, evaluate your options and choose the best for you. A, act, that is really do what you say you're going to do. And then S, for see if it worked. The see if it worked part is really very important. If you're satisfied with the outcome, then move on to another problem. But if you really aren't satisfied, then go back to your list of possible solutions, think up some more solutions, and then go ahead and try again. This is what is known as going to plan B. The most important part of a problem-solving strategy, like Bright Ideas, is that you'll be satisfied with the outcome that you are eventually able to achieve. The mother of a child with cancer will tell you about her experiences and some of the problems she has faced. She and I will go over the steps of problem solving and the Bright Ideas paradigm as she learns this particular coping strategy. And she'll also tell us about problems that she has faced in the past that would have lent themselves well to using this kind of approach.
You know, the Bright Idea program isn't just good for helping deal with a child that's ill. Honestly, it just helps in dealing with the stress and conflicts that life just naturally comes up with.
Welcome to the Bright Ideas online problem-solving skills training website. We hope that you will find it helpful to you as you cope with the extraordinary as well as the ordinary everyday challenges having a child with cancer brings to you, to your family, and all the other people who care for your child.
You want to help me get,
Yeah, just go down to the bottom.
I'll just go, yeah,
Yeah. You can access your PowerPoint down there.
yeah, got it. Okay,
There you go.
everybody's on board there? Okay, great. So just to give a little texture to this, to the intervention itself, let's imagine we come into clinic one morning, there's, say, a mother sitting in the waiting room and her head is buried in her hands. Obviously distraught, call her to her office and say, what's going on? She says, I can't take it anymore. I'm overwhelmed. Okay. Now, problem identification and formulation, we're not gonna work on everything at once, but we're gonna find, well, tell me what's going on. She said, let me tell you, my boss is ready to fire me because of all the work, I miss because I'm taking my kid to clinic. I've got other kids at home who feel neglected. And my husband, every time I come back from clinic, he's got a million questions that I can't answer. And he's upset with me because I can't answer them, and a list of other problems. So we might ask that one, well, what's most distressing to you? Okay, and they're all distressed, but let's pick one. And she'll tell you, this thing with my husband. I'm doing my best. I got other things on my mind and I got to take care of him and he's got complaints. Okay, so the problem identification is that my husband isn't happy with the answers I come back with from clinic. Okay, we then go into definition of alternative solutions. Now, this means adopting a very non-critical approach, because what do we usually do when we have a problem? We think of, okay, well, I can do this. Nah, that won't work. Oh, I can do this. Well, no, we can't do that. We have to adopt a non-critical approach, and basically, and sometimes what we'll do is start out with absurd options just to get people thinking, just to let them let go of their sort of critical mind. So, well, get rid of the guy. Okay, no, then we'll talk about, oh, well, I have him write down his questions. Now, we don't give the parent, we prompt them, well, think, what can you do? Well, I can have him write down his questions, okay? Well, I can take a tape recorder to the clinic and have the doctor, I can have, we can do a Zoom meeting, et cetera, okay? And we'll come up with a list of alternatives. Evaluation and decision making means, okay, what are the pros and the cons of doing that? Well, he leaves work early in the morning and he doesn't have patience to write down questions. That's a barrier. We look at the barriers and the enablers of each of the alternatives. And then we come up with what seems to be the best solution or best combination of solutions. It then is act, just do it. Okay, you gotta do it. Come back, evaluate it. If it worked, great. If it didn't work, then we circle back and go to other possibilities, other options. If it worked, then we go on to the next problem. Okay, so this was done, as we said, early in treatment, 8 individual sessions. The focus was on current problems. In other words, if the problem was a problem at work, we deal with the problem at work. If the problem was a problem with parking that drove the parent crazy on the way to clinic, we dealt with that, whatever was on their mind, because it's obviously a generic skill. Okay. So to the results. Now recall time 1, pre-intervention, time 2, immediately post-intervention, time 3, 3-month follow-up. So what you see here are change scores. I'm going to come up here for just a minute. Now this slide refers to the primary outcome, which was how did problem-solving skills improve as a result of intervention? Well, obviously from time 1 to time 2, it improved, that maintained at time 3. This is the problem-solving group, and this is the usual psychological care group. An improvement here, interesting why, we'll come back to that, but clearly not as much as in the group that was treated. Go ahead. Okay. Okay.
Oh, you're good. I was just hiding them.
Okay. And those, obviously those gains maintained at time 3. No change from time 2, but they maintained at time 3.
Are you arrowing over?
Put the cursor on here.
There you
Okay. These are the secondary affective measures, and what we want to see, this measures distress, so what we want to see is a reduction. Okay, so this is the profile of mood states, obviously superior to the control group, the Beck's depression inventory superior to the control group, and these and this is the measure of post-traumatic stress, the impact of events scale. Okay, so question to the group. Great, Michael. Looks like you got something here. Why did the control group, who didn't receive the problem-solving skills, why did they improve?
Regression to the mean.
What's that?
Regression to the mean.
Okay. Other ideas? Simple ideas, not statistical. People feel better over time.
That's
Right? So why treat them at all if they prove better over time? Well, you know, if you have a tooth pulled without anesthetic, you'll also improve over time. Okay. Now let's go back to this for a second and recall the design of this. And this is kind of nice because you people are researchers and methodologists. I'm a clinician for whom sort of the methodological aspects of it, they're not an afterthought, but they're not my bread and butter.
How did you measure improvement?
These are change scores.
So how did you, what's the change?
Okay, so we look at time 1 POMS, well, actually time 2 POMS.
What does that stand for?
Oh, profile of mood states, a measure of whatever psychological distress were, right? And we subtract their time 2 score from their time 1 score. And that represents the change. Okay. Good question, because we're going to later on in the talk ask, what does change mean? How much change do we need? Okay, but so these are group comparisons. Remember that, right? P-values, effect sizes, but they're all based on hundreds of people, averaging them out, comparing them, right? Okay. So people improve over time, but the major limitation of this study is that the control group simply received less treatment. right? Remember, it was usual psychological care in both groups. One group got 8 sessions of problem-solving skills. They got more treatment, whatever it was. Now, in psychology and psychotherapy research, whatever intervention you use, specific treatment you use, and you distill that, that will account for less than 50% of the variance in the improvement. Well, where's the rest of the improvement coming from? It's coming from what we as psychologists call, a medical researcher might call a placebo. Okay, we call it non-specific effects. You sit with somebody, you listen to them, you're empathic, you care, right? Feels good. How do we control for that? How do we answer the question in the study that I just showed you? How do you know, Michael, that your problem-solving skills intervention made a difference and not just kind of being with the person? So there's 2 answers to that. One is statistical. We can do a mediation analysis that looks at how much of the variance in change in the way people feel, the affective measures, is accounted for by the change in problem-solving skills abilities, okay? And the answer to that is about 40%, okay? But still, that's a statistical kind of post hoc analysis. The real way to measure it is to give people, take 2 groups, randomize them, and give them equivalent amounts of treatment, right? But the sort of control group, the control group being one that offers psychological support, but no problem-solving skills training. Follow that? So the next study, so if the first study showed efficacy, the second study was there to demonstrate specificity, okay? To compare the problem-solving skills training arm, the Bright Ideas arm, to a non-directive support condition to better define the effects of problem-solving skills training independent of the non-specific effects of social support. Got it. Again, a 2-arm randomized controlled trial. Remember that number 152, because we're going to come back to it. 152 parents received the problem-solving skills training, and 157 received the non-directive support. Okay. Interesting finding here that so we want to look at, well, as researchers, our hypothesis is that the problem-solving skills training is going to be superior. It can go beyond the human element. Okay, so this graph shows the problem-solving skills measure, the primary outcome. What we see here is clearly those who receive problem-solving skills training at time 2 and time 3 were superior to the support group. Got it? Primary. Okay, now look what happened on the 3 affective measures: the profile of mood states, the Beck Depression Inventory, and the post-traumatic stress measure. What we see here is that they're pretty similar time 1 to time 2 on all 3 measures. But whereas the support group sort of levels off between time 2 and time 3, meaning after treatment is terminated, the improvement slows down, right? Whereas in the problem-solving skills group, following treatment termination, the improvement continues. Okay? Got that? Okay. So, any explanations for that? Well, so what this demonstrates is specificity. Just being there is clearly beneficial in the moment, but receiving problem-solving skills provides the added benefit of continued skills development. This is evident even 3 months after treatment termination. So that, give a man a fish and you feed him for a day, teach a man to fish, and you can feed him for a lifetime. Okay?
Time 3 was 3 months still.
3 months.
Yes.
Right. On the basis of these 2 studies, Bright Ideas was designated as the research tested intervention program included in the registry of evidence-based programs and practices. So,
Sorry, really quick question. The control group received 8 hours of just talking. I mean, I want to understand better.
okay,
What is this
Okay.
usual source of
So
standard?
we call it non-directive support. That was the term we gave it. Okay. Non-directive support is a psychotherapeutic method. Okay, it's based on what Carl Rogers called client-centered therapy. Okay, it has to do with reflective listening. Okay, affirming, giving the person a time to express. Okay, it's a fairly passive intervention. Okay, but what was clearly delineated in the treatment both there were two treatment manuals for one for each group. And what was most important was that there be no kind of bleeding over, so that in the supportive group, there was no element of problem solving skills, training or advice or any of the steps that, and just let me, at that point, one of my roles on the study was treatment integrity. So I had to be there to listen to hundreds of sessions to make sure that the therapists were adhering to protocol and not, kind of bleeding over into groups.
Was the intervention and the usual care or attention control, were they done at different sites?
Oh, no, each site, in this study, there were like 6 or 7 sites, I can't remember, but each site had randomization.
So but the interventionists knew both protocols, knew both manuals and were delivering them.
That's right.
Okay, but you checked that there was no diffusion between.
There was a whole very strict treatment integrity protocol, including training, supervision, and like I say, this ongoing monitoring.
Have you ever compared the bright ideas versus other problem-based kind of modalities, like other models?
Problem-based modality?
Well, no, just sorry, solution, problem solving kind of.
Something,
Just like,
you could take problem solving, different it all boils down to this. It all boils down to define your problem. Okay, think of alternatives, evaluate the alternative, choose your solution, et cetera. It's extremely intuitive. And it's, and I want to say that the trainers for this were not high-level PhDs. These were mostly master's level psychologists. This can be administered by really any health professional who's trained, gets it, okay, and works with patients. So other health professionals can certainly, there's no reason to say that a psychologist or a psychiatrist does a better job than just anyone who's trained in it.
I just I'm a quality improvement specialist, so when I see the methodology, it aligns with what we use in quality improvement, improvement science methods within healthcare, typically with providers, or nurses or multidisciplinary, but you're using it now with treating patients, which I just think is really beautiful, because when I think about how I use improvement science in work, but I also use it in my daily life to do problem solving and how to measure the impact of that. And
Right.
so I just appreciate that.
Right. And in fact, first of all, it's been used with other populations. It's actually, I think its origins are in organizational psychology and educational psychology. And this is one of, and before we were doing our work, it was being applied in adult medicine. Since then, it's been used with autism and parents with, and with one of our collaborators is doing a whole line of research with young adolescents, AYA, adolescents, young adult cancer patients. Okay, so we've demonstrated efficacy and specificity. The next question was, if Bright Ideas goes beyond the human element, right, it's more than just support, can that benefit be preserved if we remove that element? Now, how do you take the human element out of it and just keep the problem solving part? You use a computer. So we developed an online version of this, and we did our third randomized trial. And I'm not going to spend too much time on this, but basically what you're seeing here is that the solid line is the face-to-face, the dotted line is the online. And one might say that the face-to-face is slightly superior, but then you have the benefits and the advantages of being a dissemination. This is a dissemination study. So the question was really how far, and there are trade-offs there, but clearly it was also possible to deliver this online. Okay, now I want to summarize these studies because they answer important questions. First of all, efficacy. Does this intervention work? Specificity, does this intervention work? And the third question, can it be widely applied? Now, and go easy on me here because I think we have a lot of methodologists and statisticians. Okay, because what I'm about to talk about now, it was born in a room like this where I was sitting with my colleagues. And I said, this is really great stuff. Okay. And I said, how many are responding to treatment? And I kind of got a response like this. It's very quiet. How many of our parents that are getting this are responding to it? Because all the studies that I've shown you are based on group comparisons. Okay. So which use p-values and clinical and measures of effect size, if we're lucky. But they do not address the most critical applied clinical question, which is responsivity. How many of those treated benefit from the intervention and who are they? And for this, we were in need of a different approach. First of all, that defined a threshold for treatment response. Now in medicine, if you're an oncologist, you can all apply this to your specialties, but hopefully there are, at least with some of the treatments, there are anchors for clinical response. I don't know, 5-year survival, remission, whatever that might be. But this is fairly new territory in psychology, okay? So the way that we approach this in the study that I'm about to show you is using in the context of minimal clinically important difference. Now, can I ask how many are familiar with that concept? Okay, so basically it asks us, how much is enough? How much improvement in whatever you're doing matters? Okay, recall again that group statistics are extremely sensitive to sample size. You can get that much improvement and have it be statistically significant if you got enough subjects, right? Participants. Okay, so first question is, what is the definition of a minimal clinically important difference? A change in outcome that's considered meaningful and worthwhile by the relevant stakeholders, such that they would choose to implement the intervention under similar circumstances. And with those meeting the MCID threshold considered to be treatment responders. This is a very gross definition. It basically asks, you have a problem, you got treatment, or you're a physician or a scientist, you gave treatment, would you do it again? Was the benefit worth doing it again? That's a very gross definition, but the ways that, again, this derives, mostly from medicine, very much from rehabilitation medicine, pain management. There are what's called anchor-based measures, and there are distribution-based measures. Anchor-based measures, and there's no one measure of minimal clinically important difference. You can ask, you can have a global assessment rating. Do you rate the patient, or does the patient rate themselves as better, unchanged, or worse? There can be a functional criteria. An important is the patient back? Are they back in school? Are they back to work? Can they walk? Can they go to the bathroom by themselves? Whatever that functional measure is. Clinical to non-clinical change, well, that's an approach where, let's say if I'm a psychologist and I'm treating anxiety disorders and I have an intervention. Question is, okay, well, I admit, 100% of my participants who have an anxiety disorder, at the end of treatment, do they have the diagnosis? If they lost the diagnosis, well, then that can be moving from the clinical to the non-clinical range. Also, different psychological measures, some of them, there are cutoffs, okay, on a depression scale. Cutoff on it's a continuous scale, right? From 1 to 100 or 1 to 30, whatever it is, there are cutoffs, mild depression, moderate, severe. So those are anchor-based measures. Distribution-based measures can look at certain statistical indices. For example, percent change. Well, I can say, well, you know, if I'm treating pain and I'm giving a 1 to 10 pain rating scale, okay, and there's a 50% reduction, then that's my measure of clinical change. That's very sensitive to the baseline. Now, the 50% reduction of 10 and 50% reduction of 6, those are not the same numbers, okay? Effect size, well, we all know what that is, you know, a small, medium, large effect size, okay? So if an individual participant improved 0.2 effect size over the group baseline score, then, okay, and then there's the reliable change index, which is basically a measure, is the change statistically reliable or is it subject to chance? So this is just a kind of taste of what this concept is and different approaches to measuring it. So in the next study, what we looked at is responsivity, meaning looking at response rates to our problem-solving skills intervention. Remember, we have a group, we want to look at individual response rates. And the idea is not only to look at what percentage of our treated participants have responded, but also who are they? What makes them respond and others perhaps not? So remember the number 152? What we did was we took the data from the participants in our previous study who had received the intervention, okay, same measures, and we used 2 measures to identify whether each one of those 152 mothers could be classified as a responder or a non-responder. And the criteria were that their individual effect size had to be more than 0.2. Okay, and the way that was measured was their own change score from, say, time 1 to time 2, divided by the standard deviation of the group at baseline. So we actually had an individual effect size, and whether that their own change score was reliable. Okay. Here's what we found. So first of all, let's go to the bottom. Responders. Who are those of the 150 that clearly benefit? Well, remember they had to have an effect size of 0.2 and they had to have a significant reliable change. 33% time 1 to time 2. 39% time 2 to time 3. And time 1 to time 3. Non-responders, people who did not improve 0.2 effect size. In fact, some of them got worse, can be, right? Okay. And that their change was not reliable, okay? Non-responders, 38, 39. Then there was an intermediate group. Who's the intermediate? Well, their effect size was, acceptable. Their change score was acceptable, but it wasn't necessarily reliable. So what we learned from here is that in those studies that clearly demonstrated the superiority of our intervention, in fact, only about 1/3 can be classified as responders. Okay. So, were we happy about this? Well, it's just the way it is, isn't it? Right? But this has great implications. First of all, it's important to determine responsivity beyond efficacy and specificity. And the reason is because a promising treatment, like Bright Ideas, may include many non-responders, many non-responders. Well, a treatment that was not found, and the opposite is true, a treatment that was not found to be superior benefit may also include some responders. That can happen too. It's important to build MCID responsivity measures a priori into randomized trials beyond group outcome measures. And it's important to determine the characteristics of the responders for targeted intervention in clinical conservation. I mean, if we're going to treat 100% of our population, when only a third is going to respond, we're wasting a lot of time and effort. In this study, it won't surprise you to find out that the strongest predictor of responders was their baseline problem-solving skills. People who came in with problem-solving, ceiling effect, right? So one easy way to assess, to identify responders, people who respond to this treatment, if I'm a psychologist or a nurse or whatever on a ward, it could be, by the way, this can be applied really to any clinical population, any pediatric population. All I have to do is to assess their problem-solving skills at baseline and say, well, no, they're okay. Magic number is 12. Okay, if they're above 12, they probably don't need, if they're below 12 on measure that we use, then they can benefit. Well, the final question that I'm going to talk about is a question that we asked, which was in our field of pediatric psychology, how well are we doing in looking at responsivity and meaningful clinical change? Okay, we do a lot of randomized trials, but how many of them go the extra step to look at responders, respond rates, and who they are? So this is a study that Dave was really my guide to conducting. And what we did was we did a review of randomized trials that were published over a decade in the Journal of Pediatric Psychology. We came up with 43 studies that met the criteria, and we analyzed all 43 studies with regard to characteristics of the intervention, of the population, was the measures, how the data were reported, but importantly, with regard to indicators of clinical significance, meaningful change, responsivity rates, and predictors. And what we found was as follows. 60% of the studies made no reference at all to meaningful clinical change, response rates, or characteristics of responders, 60%. A number of them did, 35% made mention of it, but with regard to interpretation of group differences, okay? So based on group statistics, are the groups far enough apart to meet the minimal clinical important difference? Or sometimes it's used to calculate sample size in terms of looking for the kind of differences between groups that you're looking for, or in describing the measure. 2 studies of the 43 reported criteria for assessing meaningful change to determine response rates and characteristics of responders. Okay, so clearly in our field, the findings highlight the need for greater emphasis on defining standards and analyzing treatment outcome research in terms of metrics of meaningful clinical change and treatment response. And this is really, I guess the point of it all is to better target intervention and to optimize our limited resources. So there it is. I walked you through a series of studies that describe the development of an intervention, testing its efficacy, looking at its specificity, looking at the ability to disseminate what seems to be an effective intervention, but also uncovering the dirty little secret of response rates. Okay, but again, that's not really bad news. Actually, it's good news, because by looking at that, we can look at 4 predictors of response and really save a lot of time and effort. That's it. And thoughts?
Questions. This was really interesting. Thanks for this talk. Do you think your intervention, your results would have been different if you had randomized fathers of children?
So, let's ask this, first of all, why mothers? I don't know if this is true in other areas of your research, working with parents. Mothers, there's a sort of theoretical rationale, and there's a practical. Theoretical rationale, which doesn't hold too much. I mean, is that mothers are very pivotal, so we want to target mothers, okay? But the real reason is they're just more available. And we want to do a large study of this kind with it. However, I will tell you that in the dissemination study that we did, it included fathers as well. So there's no reason not to include fathers. I have a doctoral student right now who is working on a similar kind of intervention study. And fathers are most willing, if they're accessible, to participate. There was no significant difference in the dissemination study, the online study, in the way fathers and mothers responded. They both improved in similar margins.
Another question is regarding cost effectiveness, I guess, because when you think about I think it might be mitigated, obviously, if you do a computer module, but if you're doing 8 additional sessions at X cost to the healthcare system, to get Y improvement, right? I mean, I just wonder how much, whether you've thought about that or whether there's been any thought about, well, do we get the same effect with 4 sessions as opposed to 8?
Good. So actually, this was intended as an 8 session, but in fact, some people, they may say it may be evident after 4 sessions that they get it and they're using it. The sort of intent to treat criteria was 6 sessions. They had to have completed at least 6 sessions to be included in the sample. But you're very right about the cost issue and the practicality issue. And I think that there are 2 findings here that speak to that. One is the idea of dissemination and online models, right? And the other is this issue of targeted intervention so that you're not, doing this for everybody, but only those who you think can benefit.
So along similar lines, so no matter what the issue is, people will want at the extremes, will want to or end up going back to baseline. You go running, your heart rate is up, it's going to go back to baseline. If we look at traumatic events, we'll return to baseline. In pediatric chronic illness, the number of studies show it's about a year until you're back to where you were. And back to where you were can be all over the place, right? So in healthcare, whether it's in Israel, US, anywhere, the value that's assigned to psychosocial interventions is quite low. So one has to kind of come up with silver bullets in a sense. So in terms of like cost effectiveness, because otherwise nobody's interested in the investment. So the question to you as a clinician who sees patients like this all the time, they're going to get, by and large, get to baseline over time. The intervention will help them get to baseline quicker. So the question is not only what is a meaningful difference, is how much suffering or distress do we say, no big problem? And it's not a research question. It's what would you say to a payer, to a hospital administrator, to say we should use this intervention, that it works? They're going to say, but a little suffering, not so bad.
Okay, so first of all, it touches on what I said earlier about what you're talking about, is what we call avoided distress. Okay. First of all, I think that we have to, for the payer, we have to demonstrate, first of all, that we're avoiding distress. Okay, so the first two studies don't really answer that question. The responsivity study at least answers the question. So even to approach the payer, I would have to say that I want to use this, but I want you to, I'm going to use it. I want you to pay for it with people who I know are likely to benefit. That has to be the first criteria. You know, is distress monetizable? I'll tell you what I think would be. Look, there are a couple of questions that I would ask. One is, for example, what are the secondary benefits of reduced distress? Okay, compliance. Okay, what if I can demonstrate that compliance is greater with parents, or the problem solving? My child won't take his, my teenage child won't take his prednisone. Okay. So those are the things that I think that we'd have to demonstrate to demonstrate cost effectiveness. Okay, if people were able, there has to be, look, these the responsivity criteria that I go through are primarily statistical. If they're functional, okay, because kids get back to school. Another question that wasn't asked here, which really is the next generation of studies, how does all this trickle down to the children? Do children of parents who receive this intervention, are they any better off? So there are a lot of pathways beyond distress that one would have to demonstrate that I think could back up, you know, if distress wasn't enough, that you'd have to look at.
I'd be really interested in understanding pre-post. I'd be really interested in understanding pre-post differences in the treatment versus control group in mental health utilization among mothers. Because if there's a decrease, right, if there's fewer ED visits for suicide, I don't know, is for depression,
So I have
health issues or something
okay.
like that.
I got it. So this whole line of research with the parents, it grew out of earlier studies that we were doing with sibling adjustment, series of studies that we did with sibling adjustment. And what we found there was, because we were also looking at maternal well-being and other measures. And what we found was, with the siblings, it turned out that there were really three groups. You think of siblings of, say, a child with cancer patient as a suffering along with the family, et cetera. Well, it's more complex than that. Actually, you have those who are dysfunctional as a result. You actually have a resilient group who grow, do better of our siblings. Following the diagnosis of cancer in the family, who'd have thought that? You have an intermediate group. What I want to tell you is that from the sibling studies grew the parental studies, because what we found was that mothers of dysfunctional siblings, in that dysfunctional sibling group, they had much greater utilization of all kinds of support and mental health resources, and they were much less satisfied. So, clearly, you have that aspect.
There's a question.
Of it too. If you were research participants ever involved defining, no, they were not, and that is why.
Can you read that out loud?
Yeah, go back to it. Oh, thank you. In your review, were research participants ever involved in defining the meaningful clinical change metric? So the answer is no. And this whole meaningful clinical change analysis was done post hoc. But what it demonstrates is the importance of incorporating these measures in the study itself. So what we could have done and should have done is looked at functional metrics of maternal behavior, parental behavior, a global assessment. How do you feel about the treatment? Was it helpful? Would you do it again? So that really argues for building this in ahead of time.
Just me, I'm putting a survey link up there. So you're fine, go ahead.
I'm sorry?
I said, go ahead, you're good, there's no other questions.
Oh, are there any other questions?
No.
No. Okay, so
I'm just adding up a survey link.
Thank you.
Thanks very much.
thank you all. I'd like to take a moment to acknowledge my wife. Tammy,
Yes.
we are on our 40th anniversary road trip.